I move to the next session now, and this is on interstitial lung disease, a clinical perspective, and it will be taken by Dr. S.K. Chabra. For that, I have a chairperson, Dr. D.P. Singh. Dr. D.P. Singh, can you just take over and introduce Dr. Chabra, please?
Uh, Dr. S.K. Chabra is the head of the Department of Pulmonary Sleep and Critical Care Medicine at Primus Super Specialty Hospital, New Delhi. Former head of Department of Pulmonary Medicine at University of Delhi. Awarded Von Priquet Prize of the Indian College of Asthma, Allergy and Applied Immunology. Various orations received from the different platforms. He will deliver lecture on interstitial lung disease clinical perspective. I invite Dr. S.K. Chabra to deliver his lecture.
Okay, thank you so much. So I'll be giving a outline view of a very important topic, that is interstitial lung diseases, mainly some clinical tips on how to identify these patients and how to manage these patients. Although it's a huge topic, and when we talk of interstitial lung diseases, then there are more than 200 diseases which are covered under this umbrella. So a huge topic. So let me see if I can do justice to this. Now, interstitial lung diseases, why we club them under one umbrella is because these share certain characteristics. Almost all of these 200 plus diseases have similar features. That is, clinically, these are characterized by dyspnea on exertion and cough, mostly dry. Radiologically, we see diffuse infiltrates bilateral, both on a plain X-ray chest as well as on an HRCT scan. And at this point, let me say HRCT scan has revolutionized our understanding and management of interstitial lung disease. In fact, those of us who are keen to manage interstitial lung diseases must be very good at radiology, almost as good as a radiologist. Histologically, there is a distortion of the gas exchange units. Physiologically, these are characterized by what is known as a restriction of the lung and impaired oxygenation. Now, what is interstitium? Interstitium actually is the area which is outside the alveolus and between the alveolus and the pulmonary capillary. That is, this is the area where gas exchange takes place. So it is not in the airway. Normally, airways we are all familiar with when we talk of asthma and COPD. We are well aware of the alveolar diseases, but this is an area which is generally not understood well. This term is a misnomer. Reason is that it's not only the interstitium that is involved, but adjacent area like the alveolar epithelium, the pulmonary vasculature, the smaller airways, which are the bronchioles, pleura, and sometimes the larger airways are also involved. So in Europe, the term that is used is DPLD, diffuse parenchymal lung diseases. But in America and in India, we are very happy to use the term interstitial. We are all very conversant with this term. Now, as I said, there are 200 plus diseases, so there has to be a way to classify these diseases. And this is a very simple scheme of classification. Broadly, they are a group of diseases which are clubbed under the heading of idiopathic interstitial pneumonias. These are the IIPs, out of which there are multiple diseases, and idiopathic pulmonary fibrosis. This is the most important disease. And when we discuss ILDs in general, then IPF or idiopathic pulmonary fibrosis, this is the prototype disease. This is important to understand the concept of ILDs. There are other idiopathic interstitial pneumonias. Then the connective tissue disorders, which are the autoimmune diseases like rheumatoid arthritis, SLE, and so on, they also cause a lung involvement. And histologically and clinically, this resembles the idiopathic interstitial pneumonias. So the differentiation between the connective tissue disorders, ILD, and the idiopathic interstitial pneumonias depends on the extrapulmonary features which characterize the connective tissue diseases. However, it is well known that sometimes the interstitial involvement is the first involvement in connective tissue disorders. For example, a patient of rheumatoid arthritis may not have symptoms related to the joints, may have only features of interstitial lung disease, and arthritis may develop later. So this is very well known. Then there are other diseases like hypersensitive pneumonitis, sarcoidosis, and a whole lot of other diseases which differ from IIPs and connective tissue disorders, both in terms of their features on HRCT as well as on pathology. So clearly, a differentiation classification helps us to sort out the management problems. And the most important problem that has to be addressed in the workup is it IPF or non-IPF? So there's one disease, IPF, and then there are 199 plus other diseases which are clubbed under non-IPF. The reason is that IPF has the worst prognosis, but IPF also is the disease where a lot of research has taken place in recent years, and new drugs which halt fibrosis have been developed. So the management of these diseases basically requires the first differentiation, whether it is IPF or non-IPF. The reason why we look at IPF separately from all others is the poor survival. Till recently, when the drugs were not available for halting IPF, the prognosis was very, very poor. In fact, worse than most of the malignancies. And a diagnosis of IPF is generally followed by mortality within 3 years. So that is a poor prognosis. Hence, it is very important to identify whether it's IPF or non-IPF. Non-IPF can have a variable prognosis. In fact, we have patients who have lasted 20 years or more. The disease is fairly common but unrecognized. Among all the diseases, IPF is the commonest, followed by sarcoidosis, and this is the global experience. Even in our own series at Patel Chess Institute and similar studies from PGI Chandigarh, IPF, sarcoidosis, then ILDs secondary to collagen vascular disorders, and hypersensitive pneumonitis. These are the 4 conditions which form the bulk of ILDs. In addition, there are certain occupational related ILDs and drug-induced ILDs. Symptoms and signs have a lot of resemblance. The classical symptoms of these diseases is a combination of breathlessness on exertion, which is gradually progressive, with dry cough. That is, there is no phlegm. There may be constitutional symptoms like fatigue, weakness, loss of appetite. Hemoptysis is uncommon. Presence of extrapulmonary signs and symptoms like joint and muscle symptoms, Raynaud's, GI, Sika symptoms, skin involvement, eye abnormalities, these point to a coexistence of connective tissue diseases. So these are important to recognize from patients' history and by examination so that a search for the underlying connective tissue disease can be done. So history is extremely important to start with. And idiopathic pulmonary fibrosis, which is a prototype disease in ILDs, generally affects people who are 50 plus. Sarcoidosis and hypersensitive pneumonitis affects people with lower age group. There are certain diseases, notably among the connective tissue diseases like SLE, which are far more common in females. Then rare diseases like lymphangioliomyomatosis called LAM, that also affects mostly females. There are certain diseases which are more common in patients who smoke. They are drug-related diseases, so I'm not going to details, but all these are important points which we take in the history. Physical examination reveals certain common features. On auscultation at lung bases in the infrascapular regions, especially in IPF, we get crepes which are described as Velcro crepes. Wheezing is uncommon, because airway involvement is generally not common except in sarcoidosis and hypersensitive pneumonitis. Clubbing is a very important sign, although absence of clubbing does not rule out interstitial lung disease. Because interstitial lung diseases are generally progressive. So ultimately, these will lead to development of pulmonary hypertension and then right ventricular involvement leading to cor pulmonale. So end stage ILD patients would present with signs of cor pulmonale. How the disease evolves is important. There are certain diseases like those related to occupational exposures or to acute lung injury or to fumes or toxins, viral infections, which develop very, very fast. The classical example is an acute interstitial pneumonitis, which presents just like ARDS. There are other diseases like subacute hyperstitial pneumonitis, which takes a few weeks to evolve. Majority of these diseases, especially IPF, then connective tissue diseases, ILDs, sarcoidosis, these take a few months to years to evolve. So generally the patients will come and present with symptoms which are related to long duration, that is 1 year or more. These patients, when they are suspected to have an ILD on the basis of history and examination, these are put through a series of tests in a specific algorithm to reach the diagnosis, because establishing the diagnosis, as I mentioned earlier, is extremely important, whether it is IPF or non-IPF, and then among non-IPF, which particular ILD is there. So there are a series of tests which are available. There's laboratory testing, including routine chemistries and serological tests to identify connective tissue disorders, for which a battery of investigations are available. Then lung function testing is extremely important. We need extensive testing, so that will include spirometry, lung volume estimation, diffusion capacity, blood gases, a 6-minute walking test. So this gives a fair idea about the physiological impairment. And secondly, these tests are used to assess response to therapy and also label whether patients are responders or non-responders to treatment, so that unnecessary treatment is also not given to these patients. Imaging is very important because a good HRCT film, and that should be a 1 mm cut, taken both in deep expiration and deep inspiration, and then a multiplanar reconstruction is done. So this can give a fair idea about the diagnosis. In fact, IPF is one disease where if you get a classical picture on HRCT, then no other investigation is required. The HRCT positive predictive value for diagnosis in IPF reaches 100%. Similarly, there are other diseases like sarcoidosis, hypersensitivity pneumonitis, which I'll be showing a few examples. The HRCT is fairly diagnostic. So for a pulmonologist, it's very important that he also becomes a very good radiologist. Then in certain patients, we require histological proof. So we have got invasive tests like bronchoscopy and lung biopsy. So let us discuss how we do these studies in these patients. So for establishing congenital diseases, there are a whole set of tests available specific for certain diseases. But in general, because some of these diseases can start in the lung, so the initial workup would include an ESR, a CRP, an ANA to suspect that there might be an underlying congenital disease, rheumatoid factor and anti-CCP in all patients where we suspect an ILD. Others will depend on whether there are extrapulmonary signs suggestive of another congenital disease. Lung function testing, as I said earlier, has to be detailed testing, and that will establish the classical changes that include restriction, which means small lungs, a reduced vital capacity, a smaller total lung capacity, and a diffusion capacity which is reduced, reflecting the site of the disease, that is the area where gas exchange takes place. There are few diseases like sarcoidosis or HP where there may be obstructive lung function changes, but by and large, ILDs lead to restrictive ventilatory defects with diffusion impairment. A 6-minute walk test is a very important test, which can be done in any clinic. This requires no instrumentation except a pulse oximeter, and patient walks for 6 minutes at his maximum pace. It's a submaximal test, and patients with ILDs generally develop oxygen desaturation, that is, the saturation falls by more than 4%, goes below 90%, and then recovers when the patient rests. So this is the hallmark of these diseases, that there's due saturation on exercise. Lung function testing is important at all stages of the disease diagnosis, as well as to decide the treatment and to monitor the disease activity and the response to treatment. So detailed physiological evaluation can sometimes show changes even before typical signs on HRCT appear. So gas exchange abnormalities, which can be demonstrated on diffusion capacity test, on a 6-minute walk test, and even on a blood gas analysis. So these are the physiological hallmarks of this group of diseases, the ILDs. ABGs will show a type 1 respiratory failure in a more advanced disease because these patients hyperventilate, so they have a respiratory alkalosis. Later on, when the disease enters a late stage, then pulmonary hypertension develops, right ventricular involvement develops, leading to right ventricular dysfunction. So a good echocardiography is required in more advanced patients. This is a classical spirometry loop, a quick rise and quick fall, which is the opposite of what we see in asthma and COPD. We do lung function tests to monitor the disease, and once the patient is started on treatment, then spirometry every 3 to 6 monthly, diffusion capacity 6 to 12 monthly, and 6-minute walk test 6 to 12 monthly to monitor the progress of the disease. When FVC and DLSO they increase by 10% on follow-up, it means the patient is responding to treatment. Or they remain stable, then also it's taken as a criteria for response, because not all diseases will respond well to treatment. In fact, IPF, when we did not have the currently used drugs, then it was a uniform downhill course. So these patients were given unnecessary treatment with steroids, leading to adverse effects. So patients who are non-responders, that is, there is a decrease in FVC and diffusion capacity by 10% with the best treatment that we are giving, then there is no point in persisting with pharmacological treatment. We have to explore non-pharmacological treatment, including lung transplantation. Radiology forms the cornerstone of diagnosis. We start with a plain chest X-ray to suspect ILD, but it is really the HRCT which gives us the diagnostic clue. Again, to reiterate, IPF can be diagnosed just on the basis of HRCT and no other investigation is required. In HRCT, we look for a number of features like what is the nature of abnormalities that we are seeing, whether it's a reticular or a nodular kind of pattern. What is the distribution? It is centrilobular, it's perilymphatic, random, upper lobe or lower lobe, because these diseases, although they have a diffuse infiltration, yet they have specific features which help to identify. So a typical patient will have this kind of presentation, a chest X-ray showing what is described as a reticulo-nodular pattern, more prominent at the basis. Quite often symmetrical, but maybe asymmetrical. Small lungs. And UIP, this is what we have to look for in the first instance. That is a usual interstitial pneumonia, which is a subpleural involvement. This is subpleural with honeycombing, a small air cyst with traction bronchiectasis, no nodules, and the central part remaining unaffected, especially in the early stage. Now, this is important to determine. Reason is that if this pattern is there, then this is diagnosis of IPF and nothing else is required. If there are other features, and these are features of non-IPF diseases, so they would be cysts, mosaic attenuation. So anything other than the UIP pattern, then the patient has to be investigated whether it is some other IIP or other disease like hypersensitive pneumonitis or sarcoidosis. So the first question in HRCT analysis is whether this is UIP or a non-UIP. So we look for typical feature of UIP and for other features. For example, if there is a dilated esophagus, so that would suggest possibility of progressive systemic sclerosis. Pleural plaques, pleural involvement is never a feature of idiopathic pulmonary fibrosis. Extensive lymph node involvement, this would suggest sarcoidosis. So that way, we assess HRCT and think of other alternative diagnoses. And these are some of the alternative diagnoses. For example, this is a patient with sarcoidosis, where there is bilateral hilar lymphadenopathy, something that we do not see in UIP pattern in IPF. Typically, peribronchial nodules in a clusters, so this is a typical for sarcoidosis. A non-specific interstitial pneumonitis, NSIP, which is the next common idiopathic interstitial pneumonia, but with a better prognosis. This has more of a reticular pattern, not strictly distributed to the subpleural region, more uniform. Hypersensitive pneumonitis has areas which are described as air trappings. They are lucent areas, areas of ground glassing, nodules. So the HRCT has to be analyzed, and we need, as I said, a 1 mm resolution, 1 mm cut to properly make a diagnosis. So good HRCT reading often gives you the diagnosis, and you only need to confirm if at all required. So not all patients will require invasive investigations. So that is the next question to be answered, whether we should go in for a bronchoscopy and a biopsy. So this is individualized, whether do a bronchoscopy or not. If we want to do a bronchoscopy, only ball, that is a bronchoalveolar lavage, or go in for a biopsy. The biopsy could be a transbronchial biopsy, or more recently, what is known as a cryobiopsy, which gives us a bigger bit of lung tissue, about 6 to 7 mm. Then there are more invasive methods of biopsy. One is a VATS, that's a video-assisted thoracoscopic surgical biopsy, where a port is made in the thoracic wall, and then we put in a laparoscopic type of instrument and take a biopsy. Or open lung biopsy is that it is done under GA in a OT setting, and the patient is actually opened up. Ultimately, it's a clinical radiological discussion on whether to proceed with a bronchoscopy and or a biopsy. Like I said, for IPF, if we are getting a UIP pattern on an HRCT, then biopsy is not required. Many patients come late in the course of the disease, may not be fit for biopsy, so then we have to only make do with an HRCT and plus some serological investigations if relevant. So biopsy has to be considered decision, discussed with the patients, because there are complications like pneumothorax and bleeding. So only when it's going to change the management, only then we should go in for a biopsy. A lavage may help in certain cases, not all cases. For example, alveolar proteinosis, the ball is very typical, showing a milky and cloudy ball which stains positive for periodic acid shift. Infections like pneumocystis, which can resemble an acute interstitial pneumonitis, these can be picked up on a bronchoalveolar lavage. Then lymphangitic carcinomatosis, which is another disease which resembles an ILD, this can be detected on a ball fluid. Eosinophilic lung disease can be diagnosed when a high percentage of eosinophils is found in ball. Ball lymphocytosis suggests a possible diagnosis of sarcoidosis and hypersensitive pneumonitis. So ball has its uses in establishing certain diseases, but generally it is non-specific. Similarly, a transbronchial lung biopsy is most useful in sarcoidosis or in lymphangitic carcinomatosis. In other diseases, it may or may not give sufficient material to establish the diagnosis. Sometimes we are lucky we can make a diagnosis of hypersensitive pneumonitis or bronchiolitis obliterans. But in idiopathic interstitial pneumonias, in connective tissue ILDs, TBLB is of no use. So this is not attempted if our clinical diagnosis is IPF. Cryobiopsy gives a bigger yield because we freeze the tissue and take a bigger bit. So that gives a good piece for histological diagnosis, but it also has a higher risk of complications. So only when a diagnosis is not established by clinical features and by HRCT and by serology, then we think of going in for more invasive procedures. So our approach to diagnosis is that first a detailed history examination, then a assessment of the patient's serology, occupational exposures, environmental exposures, drug exposures. Then HRCT, if that establishes the diagnosis, that's the end of the search. Otherwise, we proceed on to BAL. And if that also doesn't help to establish the diagnosis, then we go in for a lung biopsy. So it's a stepwise approach. And ultimately, it's a multidisciplinary approach which is required. The clinician, the radiologist, and the pathologist, they have to sit together and make a diagnosis. And whenever the three people put their heads together, the diagnostic yield improves. In India, the clinicians most often act as radiologists also. So like I said in the beginning, a pulmonologist and a physician who's interested in pulmonologist must be a good radiologist also. The pathologist comes into the picture when a biopsy is taken. A brief word about the management, because the diseases are so many, so I won't be going through details of the management, but broad principles. Steroids and immunosuppressive agents are good for non-IPF disease in general. So most of the non-IPF patients would receive corticosteroids either alone or in combination with other immunomodulating drugs which have steroid sparing actions. And these days we are using mycophenolate mofetil or MMF quite a lot. Earlier we used to use azathioprine and cyclophosphamide. So these are good agents to help in reducing the steroid doses. IPF is a distinct disease. That is why our search starts with whether it's IPF or non-IPF, because there are two drugs which have been introduced recently. These are antifibrotics, and what these drugs do is that although these will not reverse the established disease, these will retard the further deterioration of the disease. So a patient who is progressively going downhill, at whatever time we start these drugs, hopefully the further decline is reduced. So these drugs have improved the outlook for patients of IPF, where the survival was 3 years earlier, median survival. Now it is extending to 8 or 10 years. There's a new entity which has been recognized in the last 2 or 3 years, which is PF-ILD or progressive fibrosing ILD. Many of the other idiopathic interstitial pneumonias, hyperpneumonitis, connective tissue ILDs may take a turn for the worse, about a quarter of these patients, and these patients develop a lot of fibrosis. So because fibrosis becomes the dominant pathology in about a quarter of these diseases, so these antifibrotics have been tried in these drugs, and there are trials available now which have shown that these are useful in these entities also. So if non-IPF diseases are developing fibrosis on steroids and immunomodulators, then we can step in with antifibrotics. Whereas in IPF, there is absolutely no role for corticosteroids, although before 2011, we used to use steroids a lot in IPF, but now these are not used in IPF. So no steroids, no immunomodulators in IPF, steroids and immunomodulators in non-IPF, and non-IPF worsening, there is a role for antifibrotic medications. Overall management is more than just giving drugs to these patients. So we have to identify comorbidities, and then there are a whole lot of non-pharmacological interventions which are required in these patients. Ultimately, many of these patients will go into chronic respiratory failure and require ambulatory or home oxygen therapy. A regular vaccination is required, pneumococcal as well as annual shots of influenza for these patients. Pulmonary rehabilitation is a very important area, which includes exercises as well as their social and psychological rehabilitation, nutritional assessment, and training. So this improves the quality of life and reduces dyspnea. In fact, this has to be started right at the very beginning along with the pharmacological therapy. Those patients who are not going to respond to these therapies, and generally we know in about a year's time that these are non-responders, then these are candidates for lung transplantation. Patients with IPF who were not given antifibrotics, the only treatment available was lung transplantation. But now, since antifibrotics have appeared and more are going to come, so their outlook has improved. So a multimodal approach is required, and these interventions may be required at the time of diagnosis or anytime during the course of the disease. These patients have several comorbidities, so which have to be identified at the time of presentation, or these may develop later on during the course of the disease. So during the course of the disease, we have to be on guard for these comorbidities and intervene as and when these develop. Gastroesophageal reflux, cardiovascular morbidities, proneness to DVT, risk for lung cancer, diabetes, especially with treatment with steroids, pulmonary hypertension late in the course of the disease. So these are going to appear either at diagnosis or later on during the course of the disease. Then depression and anxiety, these are important because these symptoms don't respond very well to treatment. Then non-pharmacological treatment, just to show one slide because time is not enough. So oxygen therapy I have mentioned. There are indications for oxygen therapy, then home NIV, rehabilitation, palliative care. So to summarize, ILD is a complex category of diffuse parenchymal lung disease that can be challenging to diagnose and manage. A good history, laboratory studies, HRCT scans, and if necessary, histopathology can provide the diagnostic clue. So we need to separate out IPF from the other categories, and then in the non-IPF, try to establish which disease we are dealing with. Ultimately, it has to be a multidisciplinary discussion. ILDs differ in natural history and management, so we must try to reach a correct diagnosis. All ILDs cannot be treated in a similar manner. Diagnosis should be made early and correctly so that the outcomes can be improved. So I'll stop here and hand over to my chairs. Thank you very much.
Thank you, sir. Thank you very much. Dr. DP Singh, do we have any questions for Dr. Chabra, sir?
Yeah. Sir, we are using in number of patients, we are using perfenadine and nintedanib in COVID patients.
Yes.
Do you suggest?
When COVID struck in the first wave, then there was a lot of concern that these patients may develop an irreversible disease, and these drugs were used a lot. But studies have now come which show that COVID does not lead to a progressive lung disease. It is a one-time damage, and majority of patients on follow-up at 3 months, 6 months, 12 months, they will slowly improve. So at the moment, there are no guidelines which recommend the use of antifibrotics in COVID-19. We are not using antifibrotics in these patients.
Okay, sir. Thank you.
So you said steroids are not indicated, but even for emergencies, steroids are not indicated?
In chronic patients of IPF, steroids are not indicated, but some patients with IPF go into what is known as acute exacerbation of IPF. So there it's an acute emergency. That's a different presentation like an ARDS. So there we use steroid, but only in acute exacerbation for IPF. In non-IPF, of course, steroids have a role.
They have a lot of role.
Yes.
Thank you, sir. Thank you very much.
I have one question.
Yeah.
Just
please.
one question. Sir, you mean to say this COVID-induced fibrosis is reversible?
Yes, there are a lot of papers now. In fact, a recent paper in, I'm not saying reversible. The patients will be left with damage, but it's not a progressive lung disease. So it's not, the treatment of ILD is to retard fibrosis. The drugs like nintedanib or perfenadine, which we use in IPF, this is to reduce progressive lung disease. So COVID doesn't fall in the category of progressive lung disease. So it's not going to, whatever damage has occurred, that's only going to improve with time or remain static. Just like in tuberculosis, we have a destroyed lung. So patient is left with impairment. So a lot of patients COVID will be left with impairment, but that will not progress with time.
Thank you.
A lot of them improve also. Yes.
Okay.
It was a nice presentation by Dr. S.K. Chabra. Now I hand over to Dr. Anand Minawat.